Okay.
We're ready.
Yes, we're ready.
We're here celebrating the 11th Annual Encephalitis Conference here in North America, FACES 2014 Encephalitis Conference. My name is Wendy. I'm president of Encephalitis Global, and I am an encephalitis survivor.
And I'm Dale, and I'm on the board of directors of Encephalitis Global, and I'm an encephalitis survivor.
And I'm Ingrid, and I'm an encephalitis survivor since 1995, and I am also on the board. And in addition to celebrating our 11th meeting, we are also celebrating the International Encephalitis Day, the first one in
the World
Encephalitis Day with the British Encephalitis Group. So we're here, and this is our largest crowd this time, and we're having a great time. So.
Excellent large crowd.
Yeah, really great. So.
Good afternoon, everybody, and it's an honor to be here to share some of what I know about encephalitis and encephalopathy. I deal mostly with children, but although they say it's a rare disorder, I see a lot of it in clinic. So when I do these talks, my main objective is to raise awareness of autoimmune or immune-mediated encephalopathy because it's very important to arrive at a timely and swift diagnosis and treat, because it will minimize morbidity, mortality, and hopefully improve outcomes. And then to explore available diagnostic and therapeutic strategies, and then encourage alliances for research, and also identify future research paths. So when I was invited to talk, I was also given the opportunity to read the book Understanding Hashimoto's Encephalopathy. Thank you very much for that. And just the first 4 pages, in the foreword alone, this is from the second paragraph, and I quote, "Unfortunately, HE is not well understood, and patients often face an enormous struggle trying to find the correct diagnosis. Many neurologists have never even heard of the condition," so true. "Misdiagnosis is the rule more often than the exception. HE patients and their families almost universally find themselves having to do their own research." And you know what? That HE you can substitute with any of the other autoimmune encephalitis, encephalopathies, and it'll work, because that's true. It's not in the attention of mainstream medicine. So to first differentiate encephalitis and encephalopathy, I picked this up from NINDS, which is the National Institute for Neurologic Disorders and Stroke, which is under the wing of NIH, National Institute of Health. Encephalitis is irritation and inflammation of the brain, usually occurring in an acute manner. When you say encephalopathy, it's a diffuse disease of the brain that alters brain function much more than structure. When you have an encephalitis, a lot of times you will have objective evidence, an abnormal MRI, abnormal CSF, whereas when you have an encephalopathy, you will have subtle changes, maybe. You might have some subtle EEG changes, again, maybe. But a lot of times, things that neurologists or other doctors do not understand, they only know something's wrong with the brain, get lumped into encephalopathy. Fortunately, there is an ICD-9 and ICD-10 codes for encephalopathy that we can use to get treatments made, to get diagnostic studies done. So the clinical features of encephalitis, usually there's a prodrome of mild flu-like symptoms. A few days before the actual onset of the encephalitis, you feel achy, you may have a low-grade fever or even high-grade fever. Then you have headaches, fever, vomiting, altered mental status, you can have seizures, hallucinations, visual disturbances, and if the meninges, the lining of the brain, is involved, you can have neck stiffness, which is nuchal rigidity. Whereas encephalopathy, the hallmark is an altered mental state. So usually they just come to you lethargic, confused, disoriented, and you don't know what happened. There's a progressive loss of memory and cognitive ability, personality changes, inability to concentrate, lethargy or progressive loss of consciousness, and you can also have the more solid neurologic symptoms of involuntary movements and seizures. Typical causes for encephalitis, usually infectious, viral, bacterial, fungi, and parasites, and you can also have non-infectious causes. In encephalopathy, while you can have infectious causes, it is more often than not metabolic, mitochondrial, exposure to toxic elements, trauma, brain tumor, stroke. But the diagnostic steps are similar. Most doctors will have to get a good clinical history and exam, and unfortunately, this is a learned skill. They will teach you the basics in medical school, but in this day and age, I often see my own residents when I was in a teaching hospital. Before they look at the patient or talk to the patient, they go to the computer and read the chart. They look at the lab results. It's like they have something already preconditioned in their brains before they actually talk to the patients. It's like the reverse. Then you get the CSF analysis, imaging studies, EEG, antibody testing, serologic testing, even brain biopsy. Now, this is how we typically classify encephalitis. Again, this is from the NINDS. The broad classification, infectious versus non-infectious. For infections, there's viral and non-viral, non-infectious, this. So for viral encephalitis, these are all the different viruses that can cause encephalitis. And I know that some of you mentioned CMV yesterday, herpes simplex, which is the most common. Somebody mentioned mono. So, and I've seen most of that, even influenza. And no talk on encephalitis will be complete without a talk on herpes simplex, HSV encephalitis, or HSE. It is the most common cause of sporadic fatal encephalitis. Incidence rate is 1 to 3 per 100,000, but look at the mortality. Even with treatment, it's 30%. 3 out of 10 people with encephalitis, even adequately treated, will die. 90% is from HSV1, and this is for immunocompetent patients. And the question here is it viral reactivation or is it primary infection? Clinical features: headache, fever, neck rigidity, changes in level of consciousness, personality and behavior, focal neurologic signs, cognitive disturbance, seizures. But even mild cases can actually occur. Fever is almost universal. Headache can be found in 90% of cases, and it is always of acute onset, and this will differentiate it from the other forms of encephalitis. Seizures, personality change, and focal neurologic deficits. Now, the reason I go through this is because most of the time, when you go to the emergency room or your doctor and there is concern for encephalitis, the first thing they want to rule out is HSE. 1, because there is treatment available, and 2, you want to prevent them from dying. It is actually 70% mortality rate without treatment. So how is it diagnosed? You've got typical MRI changes in the temporal lobes. You've got your EEG changes also in the temporal lobes, and 95% of CSF analysis will be abnormal. HSV1 PCR is 98% sensitive, 94% specific, and this is true about 2 to 10 days after onset. So if you're there within 24 hours and they test for your PCR, it can still be negative. You need to be retested. If you come to them 3 weeks after your symptoms have started, it can still be negative, so you just have to retest.
I have a question. On the MRI, I know a lot of times the MRI is normal, even if somebody has encephalitis. Is it more frequent that you can actually see the results for HSE?
We usually can see more changes in HSE, usually, like I said, in temporal lobes. But again, if you take the picture too early, you're not going to catch it.
Okay.
So a lot of times, if there's a delay, like you wait a week or so, then that's when we get it. So, and there is, like I said, treatment available, IV acyclovir. That's why for pediatrics at least, if there's a suspicion for HS encephalitis, we start them on what we call empiric acyclovir until the labs. We don't wait for, we draw the labs and then we start the medication. Because you can always stop the medication if it turns out to be not herpes. Corticosteroids are controversial. Some say it helps with the swelling and the inflammation. Some say it worsens it. But the funny thing is, if it is a non-viral encephalitis, let's say it's Hashimoto's, the steroids actually help. But then they think they treated the herpes. And then supportive measures: if you have seizures, you give anti-seizure medications. If they need fluids, if they need oxygen. So that's how you help them survive. So these are, like I said, the non-viral causes of encephalitis. You've got bacterial, TB in endemic countries. And this is the reason why it's very important to give history of travel, foodborne, mosquito bites. Did you go to Lyme country, the east coast of the United States? And this is why all those questions are asked when you go to the doctors. So now we go to the non-infectious, which is a lot more rare, but we're seeing it a lot more too at this time. So the antibody ADEM stands for acute demyelinating encephalomyelitis, which they think is a reactivation, or it's like an immune response, a later infection, a later response to a previous infection. A lot of times it's post-vaccination. That's why we see it a lot in children. And then you have the antibody-mediated and the seronegative autoimmune. And that's very hard to diagnose because we don't have any proof. We think it's autoimmune, but all the testing that we do is negative. Yes?
Particular vaccines or just?
No, you can get it from flu vaccine, polio vaccine, so non-specific. Let me give you a little historical perspective so you know the controversy, why it's so controversial. In the 18th century, Dr. Edward Jenner was countryside, a rural physician in England. He noticed that dairy maids who had cowpox were protected from smallpox. They didn't get smallpox. So he introduced the concept of inoculating subjects with infectious cowpox material to protect them from smallpox, which killed. And he collated data, much like what we're doing now for encephalitis. He presented this to the Royal Society of Physicians in England, and it was rejected outright. They said, it is incomplete and unconvincing, so much at variance with established knowledge, with also incredible. So in other words, they thought he was a quack, much like what we doctors experience sometimes from our colleagues. But now this work preceded that of Louis Pasteur, who actually did most of the research, who is recognized as the one who did the germline theory. So it preceded his work, Pasteur's work, by over 100 years. And yet 200, 300 years later, World Health Organization has eradicated smallpox, nearly eradicated polio through a vaccination program. So you see how the pendulum swings back and forth? So right now, this autoimmune, immune-mediated brain disorders, we're just at the cusp, we're at the beginning. Like I told you yesterday, I have some colleagues who think I'm a quack. I tell them, no, I'm cutting edge. Now, let me give you four. These are all pediatric patients of mine. RZ is a 12-year-old left-handed male, was in good health until November 2008 when he presented with a fever and a rash. He was residing in Philadelphia at that time, so he was diagnosed with Lyme disease. He had positive tests, so he was treated, he recovered. In November 2011, he received a flu shot, the one with H1N1, and within 24 hours, Mom described him as a different child. Severe anxiety, inattention, hallucination, delusions, and involuntary movements. And in December 2011, he began to have seizures. But the EEG only showed diffuse slowing. In fact, Mom had said that he almost died. Let me give you case number 2. VL is a 16-year-old right-handed female who at the age of 10 in 2003 presented with seizures with an abnormal EEG, but she also had additional symptoms of mutism and delusions. So for the seizure, she was placed on oxcarbazepine, and she was placed on haloperidol and Depakote for the psych symptoms. Very slowly, those symptoms resolved, and by 2005, she was off all her medications. On July 30, 2009, she had 3 seizures in a 24-hour period. This is after being seizure-free for 4 years. The EEG did not show anything. Remember, it was abnormal before. It had evidence of seizures. Now her EEG just showed slowing. Within a week of this, she was in a psych unit because of severe anxiety, confusion, paranoia, hallucinations, and aggression. She threw a bedpan at a nurse. Well, it was plastic, but it was still a bedpan. So, case number 3, 14-year-old right-handed female who presented at the emergency room with acute onset lethargy. She had difficulty waking up or keeping alert, and 3 generalized tonic-clonic seizures, each lasting about 10 minutes. And again, the EEG just showed diffuse slowing. 3 days before this, she had low to moderate grade fever, muscle weakness, and a rash in her hands. At the emergency room, her exam was normal, her labs were mostly normal, including CSF and serum studies for infections. At the emergency room, they already thought of herpes, but the PCR was negative. And then within 24, almost 1.5 days later, she developed visual hallucinations, language impairment, and memory problems. Case number 4, AK, is a 12-year-old right-handed male. At the age of 6, initially complained of sore throat. Within 6 weeks, developed vocal and motor tics, and in 6 months had severe coprolalia. This is a 6-year-old boy who had no real exposure to sexual language and was swearing like a sailor. She had severe OCD behaviors and paranoia, and then began to develop choreiform-like movements. He was seen by outpatient psychiatry and neurologists and diagnosed with Tourette disorder and severe OCD, but the psychotropic medications given him only worsened his symptoms. This was the child that on our table yesterday I mentioned that the mom was informed, you need to go see a psychiatrist yourself so you can accept the fact that your son is mentally deranged. That was a psychiatrist who told mom in front of her then 7-year-old son. And no labs, no imaging, they just basically labeled the little boy as, you're crazy, can't do anything about you, give him meds. No testing, nothing. Diagnosis. Now, because we're in an encephalitis conference, we all know that these are probably forms of encephalitis, but what are they? So case 1, we gave him Vimpat, Onfi, and Depakote for the seizures because nothing else worked. We worked him up for autoimmune encephalopathy. His serum NMDA receptor antibody was negative, but CSF was never obtained. But he was in the East Coast. He was able to, the parents were able to contact Dr. Dalmau, who is the researcher for NMDA, and so he was started on IVIG and had very good response. He has actually been seizure-free since May 2012, but continues to need IVIG every 3 weeks. The second case was a little bit more confusing because they thought it was rheumatologic. They thought it might be lupus encephalitis. And so she had elevated SED rate, positive ANA, SSA, elevated DNase-B antibody. DNase-B is a strep antibody. So they gave penicillin, and we also started IVIG, plasmapheresis, IV solumedrol, nothing worked. She had positive serum NMDA receptor antibody and a negative paraneoplastic panel. The only sustained response we had was with cyclophosphamide. She was also placed on carbamazepine and Seroquel, and she slowly improved, and the only thing left is a little memory, short-term memory problem and ADHD. She hasn't had any recurrence of her seizures. So I last saw her in late 2012, but at that time, their family had decided to move back to Mexico, so I haven't seen her since. So, case number 3, the seizures did not respond to Depakote, phenytoin, and Topamax. We did check for autoimmune status. Her thyroid function tests were normal, but TPO antibody and antithyroglobulin antibody were elevated. I believe if normal is like less than 100, I think, hers was like 1,300. It was over 1,000. So we gave her IV solumedrol at 1 gram per day for 3 days, and then followed by 60 milligrams oral prednisone daily. See, remember, this was within a week of the presentation of her symptoms. I guess, I don't know, I don't want to lift my own bench, but it was just fortunate I was on call, and I have interest in autoimmune encephalitis, so we started this route quicker rather than slower. And so we did get impressive clinical improvements in those first 2 weeks of treatment, including the neuropsych symptoms. And an outpatient follow-up, this was mid-2013, she was totally symptom-free, although as we were going down on the steroid, she did have a breakthrough seizure. And we're now tapering. The last time we saw her, we were planning on getting her off the anti-seizure meds. But she's young. Case 4, this was a sad one because the little boy saw 17 different specialists, but it was only after mom connected with an NIMH researcher that she started getting answers. He had elevated antibody titers to strep and mycoplasma. Normally, when you look at mycoplasma titers, the antibodies, 0.9 is your cutoff. Anything higher than 0.9 is considered positive. This little boy had a mycoplasma IgM, indicating that the body was still fighting the infection, of 15 point something. It's 15 times normal. Even the strep was in like the 7,000s. So he received IVIG and antibiotics. He has been steadily improving, but because he's constantly exposed to strep in school, he will get mild flares. He only has mild vocal tics at present. And mom describes that after having lost her child cognitively, physically, and emotionally, she now has him back. So these four are a picture of what out-of-the-box thinking maybe can do, because you get to a diagnosis quicker rather than delayed, and you can initiate treatment because you do get good responses. But unfortunately, like my little boy, 17, I was doctor number 18. So the immune system, what is its function? It protects us from a myriad of infectious organisms, and it preserves the uniqueness of the individual. A fundamental aspect of the immune response is the ability to distinguish foreign molecules from self-molecules. So when you get disorders of the immune system, it's that you're hypersensitive to something, or you're attacking your own body, autoimmunity, or you've got deficient immune substances. Now, autoimmunity was a term coined by a German immunologist, Dr. Paul Ehrlich, to describe the body's innate aversion to immunologic self-destruction. He coined it horror autotoxicus. I don't know how to pronounce it. It's Latin. Literally, the horror of self-toxicity. But the concept of autoimmunity as a cause of human illness is new to modern medicine. It wasn't really generally accepted until the 1950s or 1960s. And this is only 40, 50 years. Now remember, Dr. Edward Jenner, 100 years. So we're only halfway there. So another 50 years maybe. So this is what forget the thing that's written. Just look at the picture. Your normal immune response, an antigen invades, antibodies form. The antibodies remove the invading antigens, and then you get better. The antibodies circulate and make sure that your body's protected. Okay? In autoimmune disease, your immune system decides to form antibodies against yourself. They attack those antigens, and so inflammation and tissue damage result. The cause is largely unknown, but it is likely multifactorial, with environmental influences and genetics playing a role. And I see more and more genetics. Why? I have children who presents with, say, pandas or NMDA, and we take the family history. Oh yeah, my grandmother had rheumatoid arthritis. My mom had thyroiditis. You know, it's very common to see that in the family. But exactly what genes are involved, that's up to research still. So this is a basic idea of the etiology. You've got environment like viruses, bacteria, drugs, chemicals, toxins. You have random variables. You've got gender, genetic susceptibility, and unknown factors, and that's the big question mark. Oh, I don't like this slide. That's too medical. But I like the cartoons much better. But molecular mimicry is how we think rheumatic fever and Sydenham's chorea and pandas work. For the rest of the autoimmune brain disorders, it can be any of these other things. What is its epidemiology? Now, there are different autoimmune disorders. There are some which are organ-specific, like Hashimoto's thyroiditis, and there's more that's more systemic, like SLE, or rheumatoid, or joints like rheumatoid arthritis. So the incidence rates will vary anywhere from less than one newly diagnosed case of sclerosis to more than 20 cases of adult onset RA per 100,000 person years. The prevalence rates again range from less than 5 per 100,000 to more than 500 per 100,000. Generally, it affects about 3 to 8% of the general population and can occur at any age. At least 85% of thyroiditis, systemic sclerosis, SLE, and Sjogren's disease are female. But what I've found out is that some of the the newer concepts like voltage-gated or some of the paraneoplastic or pandas, more males are affected. So this is just a table. This does not include the brain disorders. Like RA has the highest prevalence, but they're still high. So autoimmune disorders per se are not rare in that sense, but autoimmune brain disorders are actually rare, which is why it's very difficult to accept, because the brain was thought to be separated from the immune system for many years. And this was attributed to when you do a spinal tap, there's no lymphocyte. There's no lymphatic drainage from the brain. And there's a very low level of molecules in the neurons and glia that are immune-derived. And of course, because of the blood-brain barrier, which restricts the movement of immunologically important molecules into the brain parenchyma. But there is a link. The autonomic nervous system, the sympathetic nervous system, if you've heard of adrenaline, so that's epinephrine and norepinephrine. The immune system is actually tuned by norepinephrine released locally or circulating from the adrenal medulla. And the sympathetic nervous system is actually what innervates all the lymphoid organs. Lymphoid organs is where your immune molecules come from. And these catecholamines modulate the immune system. So there is a neuroendocrine humoral outflow via the pituitary. It's so funny because we were mentioning stress. Let me show you a little cartoon. This is more medically inclined, but I like the cartoon, like I said, better. See where it says systemic insult? You can substitute that for stress. What happens with stress is that it will activate your monocytes. And in the previous slide where you see interleukin-1 and TNF-alpha up there, that is what's released. Where does it go? Now, the blood-brain barrier, specifically in the hypothalamus, is a single cell layer. Only one cell, very thin. And those pro-inflammatory cytokines can actually disrupt that membrane. And it will go to what is known as the periventricular PVN neuron or nuclei in the hypothalamus. And it will release corticotropin releasing factor, which will then act on your pituitary gland, which will then release ACTH to release cortisol. And that is how stress stimulates your immune system, and then in turn, your immune system affects the brain. So the other thing here is that the pituitary also releases thyroid stimulating hormone. And although we're talking about antibodies to thyroid substances, we don't know which receptor in the brain those substances are acting on. So immune-mediated encephalopathy comprise a large number of syndromes, many of which have only been recently identified. Why is it controversial? Because the clinical presentation often includes recent onset of progressive cognitive and behavioral problems, including inattention, hyperactivity, delusions, paranoia, and hallucinations. Imagine my 6-year-old boy who now all of a sudden is flying off the wall. And I mean, in the exam room, I've literally seen them trying to climb the wall to get to the window. So, and they will say, oh, that's just ADHD. But there's no families, nothing. It's like, how come in 2 weeks from, an attentive child, all of a sudden they're hyperactive? And nobody ever thinks that it's so acute. They say, oh, that's ADD, start him on the ADHD meds. They often mimic psychiatric disorders like schizophrenia and bipolar disorder. And so instead of getting a workup, they say, oh, this is the first, break, the first psychotic break. So get them admitted to a psych hospital. And it is challenging to evaluate because providers typically have a low index of suspicion. So these are some of the antibodies that I had mentioned. You will notice where they have the commonly paraneoplastic is usually in the membrane, and inside the cell is where you can find these antibodies, and these are usually tumor associated. Now, I only wanted to show this table because you can see that most of these antibody-mediated autoimmune brain disorders have so many psychiatric manifestations. So you can understand why they end up with a psychiatrist rather than a neurologist. And then the psychiatrist starts scratching their heads when 2 years down the road, no matter what medication they give, nothing works. This slide I actually made because as I was doing research to talk about this topic, I found that Hashimoto's, NMDA, paraneoplastic limbic, and PANDAS, they actually have a lot more in common than people realize. Acuity, they're acute and subacute. You wake up one day a different person, or you have a low-grade fever, 3 days later, you have a totally different personality. So it's acute or subacute, and that's actually one of the key things when taking the history. It's not like, oh, she was 10 and then, slowly, it's not something that evolves over years. It's something that evolves over days or weeks. Cognitive impairment, look across horizontally, memory, speech, concentration. Psychiatric symptoms, some present with hallucinations, some with mood lability, anxiety, paranoia. Other symptoms, a lot of them have movement disorders, which is dopamine. And dopamine has something to do also with hallucinations and delusions and the emotional component of speech. Antibodies in Hashimoto's, we've figured out some, not all. The antimicrosomal, this is the TPO, thyroperoxidase, and the antithyroglobulin antibody. NMDA receptor antibody, then we have the others for the paraneoplastic, there's a lot. And then for PANDAS, we are now looking at the antineuronal antibodies affecting tubulin, lysoganglioside, dopamine 1 and dopamine 2 receptors. And across the board again, treatment are all immune modulation. Steroids, IVIG, Plex is plasma exchange, methotrexate, cyclophosphamide, rituximab. And I also added this slide to show you that there's a lot more in common with the more, let's see, classically accepted, I guess, like the VGKC is voltage-gated potassium complex antibody and NMDA receptor antibody, and PANDAS, as well as Hashimoto's. Now, this statement came from PANDAS researchers, but I think it will apply to all the other antibody-mediated or autoimmune-mediated brain disorders. Symptom presentation is always acute or subacute. Variability in the type of symptoms displayed by individuals. Some will have hallucinations, others will have more paranoia and delusions. Some are more anxious, some are more ADHD. Some will have language impairment, others will have memory. Symptom profiles may evolve over time with one set of symptoms predominant at the onset, others becoming problematic after a period of days or weeks. So maybe I started out with ADHD and in a couple of weeks' time I have no memory, or the other way around. The antibodies from an infection may signal neuronal cells in some behavioral and movement disorders. I have several patients with NMDA receptor antibody whose actual symptom presentation started after an infection. The first case I presented started after a vaccine. The second case I presented, also NMDA, started after a strep infection. I have one in clinic now who started after mono. So different infections can actually trigger an underlying autoimmune brain disorder. Now this is important, I think, to present for care providers because we should overcome our cognitive bias. See, in school we are taught that if it's medical, it cannot be psychiatric. Or if it's psychiatric, it cannot be medical. Or this is purely behavioral. But my problem is this. It's like, don't human beings have only one brain? I mean, it's not divided into mental health, mental illness, and neurologic. I don't think so. It's your same brain that gives you the same psychiatric manifestations and neurologic manifestations. It's one and the same brain. So why can't we evaluate for an underlying medical disorder? I like what Dr. Anis, it's an organ. Because a lot of times if you have psychiatric symptoms, they say, oh, it's functional, or you're making it up. Curse of knowledge. One of my patients is now a 21-year-old autistic boy. And he came in catatonic. He just wasn't moving. He's like that. He's autistic, so they said, oh, he's autistic and schizophrenic. No, it turned out to be Hashimoto's. We gave him the appropriate treatment. The catatonia resolved. So just because you have an underlying developmental disorder like autism doesn't mean you can't have this too. It's more of an out-of-the-box thinking because just because, no, let me rephrase it. See, just because you have migraines for years doesn't mean that all of a sudden you have a different type of headache. I'll just attribute it to migraine. What if you've developed a brain tumor and nobody ever looked for it because you're a migraine patient, right? So it's similar to this. You have autism, you have a developmental delay, you are CP, you have cerebral palsy. It doesn't mean you can't have this. So just to break that bias. And the other one is stereotypical. You're a female, so it must be psychiatric, functional. Or there's a positive family history of bipolar disorder. I have a parent who was so upset because her 4-year-old son they were told that he had bipolar disorder. And he's 4. It's like, what life experiences can that 4-year-old have had so that he's depressed and manic at the same time? And the only thing that was answered was, oh, there's a family history on an aunt or something. Or I have been told this, oh, those diseases don't exist. It is not real. How many of you have been told that it's all in your mind? Right? So to overcome that. Now, when I was doing, I deal a lot with pandas. So when I was doing research on this, Dr. Sredo and Dr. Murphy and Dr. Cunningham are the leading researchers for pandas. So the prototype disorder, the reason they found pandas was that they were studying Sydenham's chorea and rheumatic fever. So that's a prototype disorder, and they implicated group A strep. But as research shows, there's more microbes and there are even environmental non-infectious triggers. And so they're terming it pediatric acute onset neuropsychiatric syndrome. But on my part, because I'm reading through all this and I'm seeing different types of patients, and I'm seeing the immune basis, the autoimmune, I think they're more what I call psycho-immunoneurologic disorders. Psycho because it presents a lot of times with psych symptoms. Immuno because your immune system is very much involved. And neurologic because it's your brain. It's neurologic. So why can't they all fall under the umbrella of an autoimmune or immune-mediated encephalopathy? It's an encephalitis. It's an encephalopathy. Now, I also see a lot of concussion patients, and it is surprising because the concussion patients present very much the same way. All of a sudden, they're more ADHD, even though they did not have that before. They're emotional, their mood lability, apart from the physical symptoms of headaches and dizziness. But the thing with concussion patients is that there is something that happened before they presented with the symptoms, and that's an objective finding. But if you run the same tests, the battery that we do, I use Impact, which is a computerized program. But if you give the test to somebody with encephalitis, the results are almost similar. There's a drop in almost all the scores, in visual processing, in memory, in what else is that? Matching and all of that. There's a drop. And that concussion is so recognized, and accepted as brain trauma. And I don't understand why encephalitis and encephalopathy is not accepted as something traumatic happening to your brain, because that's what it is. And who was at the table with me who went to the doctor and said, if I had a stroke and I presented after the stroke with these symptoms, who said that? Yeah. It's like, I had encephalitis, encephalopathy, and your doctor will tell you, but that was many years ago. And then you ask, if I had a stroke 2 years ago, and I presented to you right now with cognitive decline, memory problems, how are you going to treat me? And you have, oh yeah, I'm going to do this, this, and this. So how come with encephalitis or encephalopathy, you can't do that? It's like you're being told that, oh, but the encephalitis happened 3 years ago, 4 years ago. It's like, but your brain's still recovering. Now, how I look at it, this is how I explain it to my young patients. You know how we tell them, encourage learning between the ages of 0 to 6 years. Why? Because that's the time when your brain, your brain cells, the neurons, the number of neurons you have, you're done by the time you're born. But the laying of the fibers that connect, the pathways, the connections, that goes on till you're about 6, 7. There's a term called neuroplasticity. Now let's say going from point A to point B. Let's say me from home to work. I will only use the 10 freeway. But I can go to work using the 405, using the 5. God, I hate the traffic in LA, by the way. But I always use home, 10 freeway, work. Work, 10 freeway, home. That's what my brain learns. But inside my brain, the 405 is there, the 5 is there, the 605 is there. It's not just being used. Something happens to your brain, or potholes, a flood, an earthquake, and it ruins the 10 freeway. And then all of a sudden, there's no way for the signal to pass through. What rehab or treatment does is for your brain to sort of awaken the 405 and the 605 pathway that was laid down when you were 0 to 6 years old. That's why it is somewhat easier for children to recover from a concussion, to recover from brain injury than adults. Because you can still, it's some sort of neuroplasticity. And that's a very simplistic view of it. But it can give you at least an idea of how to make those connections. The connections are there. You just have to make that pathway and learn it all over again. So what do I recommend? What do I usually do? When I get calls from primary care providers, I usually say you don't have to wait for them to see me. You can already ask for serum inflammatory markers, even serum antibody titers while waiting to see the neurologist. You can order an MRI of the brain with and without GAD, contrast, EEG, and an LP. The LP is very difficult to push for in children because it is an invasive procedure, and most parents are protective of their child. As much as possible, I get it done with interventional radiology so that it's guided and the children can be sedated. Genetic studies if needed, and metabolic studies. Just as a caveat, I saw a 6-year-old autistic patient, and the story didn't sound quite right, and I ran metabolic studies. The little boy had X-linked creatine transporter deficiency. Creatine is a muscle enzyme, and to get into the brain, it needs a transporter, and the little boy did not have that. So we started him on an amino acid supplements, and all his autistic features subsided. So he was labeled autism since 18 months old. So emphasis, index of suspicion. Providers should have low threshold for evaluating these symptoms further, and unfortunately, I don't know how to convince them. Cognitive bias, because if you present with psychiatric symptoms, guess what? You are going to be sent to a psychiatrist. Autoimmune encephalopathy is very responsive to immunotherapy, especially if given early in the course. And then this one for me is important. Determine the areas of functional and psychosocial impairment imposed by both the neurologic and psychiatric symptoms. See, it's very easy for us doctors to say, okay, you have NMDA, we'll give you IVIG, goodbye. No, that's not right. Because you have to understand, how has the anxiety and the paranoia affected you going to work? How has the ADHD and lack of concentration, memory impairment affected you going to school? And this is where there is just utter lack of services. I try to have a multi-component management approach where we educate parents, partners, family, and others. Behavioral approaches, because while medication can help, I also believe something like cognitive behavior therapy can help, especially with the OCD tendencies and the anxiety. Then, of course, medication, academic and work accommodations, and psychological and psychosocial supports. The cornerstone of treatment is immunomodulatory, steroids, IVIG, plasmapheresis, methotrexate, mycophenolate, cyclophosphamide, rituximab. And some of these syndromes are associated with tumors. So we do a tumor screen, and if there's a tumor identified, remove the tumor, because that's the most effective way of treating it. For pandas, for instance, antibiotics and a tonsillectomy and adenoidectomy, and then to manage other symptoms, headaches, seizures, tremors. There are medications for that, and there's physical and occupational therapy that can help. So I am not an immunologist, but these are the ways that the immune system can be addressed. So I presented this slide, only look at the bottom, because it can help change, we mentioned diet, gluten, alcohol, other factors, vitamin A, vitamin D. I now routinely test for vitamin D in all my patients because they are almost always low, and I live in sunny Arizona. So the other thing I test for is folic acid, iron, especially if they have sleep disturbances, ferritin, and homocysteine, something that has to do with folic acid metabolism, because those are the things that are now being studied in terms of how diet, how supplements may help in these neurologic disorders. The unfortunate thing is there is still no standard practice guideline for physicians. You go to one doctor, the treatment's all different. We try, so the basic is immunomodulatory treatments, everything else, and then we don't have standard doses. When I treat with IVIG, for instance, I treat with the dose that we give for something like myasthenia or CIDP. It's 1.5 grams per kilogram per day, 1 to 1.5 grams per kilogram per day for 2 days. So it's a pretty high dose. If you go to an immunologist, you're going to get 0.5 grams, which is the immune dose. So it is still highly individualized to patient. What I give you might not work for you, for her, for instance. So it's still highly individualized. The important thing is to initiate treatment as soon as possible and then give the patient and their family realistic expectations. I treat you today, you won't get better tomorrow. Recovery occurs over months. And you can get remissions and you can get recurrence of symptoms. But if there's no improvement with the first line treatment, for steroids for instance, then go to the next. The difficulty is how long do you wait? Now, for antibiotics, in terms of that, the Sydenham-Scaria and RF model, see, the difficulty with giving antibiotics, especially to those who had a preceding infection that triggered their symptoms, is that, the threat of superinfections is very real. But then research has shown that antibiotics actually have a non-antimicrobial role. First, it can decrease the antigenic load from undetected and asymptomatic intracellular group A strep. Strep is a bad bug. It's been with us for almost 1 million years, and it's learned to hide in the human body and then come back later to bite us in the butt. The antibiotics can actually also change inflammatory cell metabolism by altering cytokines. It specifically conjugates interferon gamma, reduces its activity. It can allow normalization of tryptophan levels, which will influence serotonin metabolism. For those of you with psych symptoms, serotonin, depression, bipolar disorder. That's the main neurotransmitter that's affected by that. And also, it offers neuroprotection by promoting expression of glutamate transporter GLT1. Now, glutamate, in concussion, if you take a picture, if you take an MRI, usually it's normal. But something happens to the white matter, something called the glutaminergic surge. It has something to do with glutamate, and that can cause neurodegeneration, which is why you have all this neuropsychiatric symptoms in concussion. So antibiotics actually can help with that. And I believe there's a current study on the role of penicillin for Alzheimer's disease. Same thing with ibuprofen. So ibuprofen can inhibit COX-1 and COX-2 to prevent production of prostaglandins. Remember the chart with the stress and systemic insult going up into the hypothalamus. It also has an anti-inflammatory effect on the blood-brain barrier and prevents anti-neuronal antibodies from crossing into the brain. That single cell layer, it can help prevent that breakdown. And ibuprofen inhibits the expression of ICAM1, which promotes neurodegeneration. So again, ibuprofen is also being studied right now for Alzheimer's. So this is what's important for me to tell my colleagues. Please listen to the parents. Please listen to the patients. Do not assume that they're making it up. Evaluation and treatment requires a multidisciplinary team, and there is a need to establish clinical standards of care across medical disciplines. Like I said, I'm not an immunologist, but I refer you out to an immunologist. I will refer you out to, say, an ENT if you need a tonsillectomy or you have frequent sinus infections. I need help from a rheumatologist. So across medical disciplines, it's not like, oh, I refer you to a psychiatrist, and the psychiatrist, instead of following or even listening or looking at the notes of the neurologist, they'll just, oh no, you're purely schizophrenic, let me start you on meds. So across the board, across medical disciplines, and coordinated effort for basic and clinical research. Now, this is a statement attributed to Dr. Tanya Murphy, who is one of the leading researchers for pandas. But I think it applies to HE, to HSE, to all these new immune-based brain disorders. It is time for the NIH, together with advocacy and professional organizations, to convene a panel of experts, not to debate the current data, not to argue among themselves that it does not exist, that they're psychiatric, that it's mental health, that etc., but to chart a way forward. It's like it exists. I mean, look at this room. I have survivors. So instead of debating, let's chart a way forward. Now, that's the last of my slides, but I would like to say special thank you to the following. My family, because they put up with me. Miss Shelley Avila and Corey Zidibel. Actually, I think Nicola had opportunity to speak with them. Shelley is from Walgreens, and Julie is here as well. But they actually brought me to this group. They brought attention because they believed in what I was doing to help these children. Corey is the parent of one of my patients who has NMDA receptor antibody, and she's very proactive for her child. Dr. Troy Anderson is right there. He's my partner, and I believe he sees my vision and is encouraging me not just to do the clinic research path, to affiliate with universities to learn more about this, but also to help patients because he's an adult neurologist. So special thank you. Now this last slide, when I first started speaking, see that far corner? That was the only thing I had because I started with pandas. And then the NMDA. And then now that. So thank you so much. Thank you. Yes?